You're like, I got this. Hi, everyone. Good morning. Thank you so much for joining. This is Firearm, Morbidity and Mortality in the U.S. and Beyond, Critical Research and Public Health Initiatives. I think it switched this morning, so we might have some people wandering in and out about which salon it was in. So you have found the correct salon if this is what you were looking for. It will be Dr. Hargarden, who's down sitting here over to my left, farthest way. Myself, my name is Christian Pulcini. I'm a pediatric emergency medicine physician at the University of Vermont, and Dr. Megan Rainey, who is here as well. These are our disclosures. Do I have to read through these? Thank you. Okay. These are our disclosures. Our objectives for today are to describe the current state of firearm injury prevention in the U.S., including research and public health initiatives with an emphasis on federal funding and emergency medicine, specify 2 gaps in our current understanding of firearm injury, and to provide an illustrative example of active research that fills a current gap, and further how that can inform public health and policy efforts to mitigate firearm injury. It's probably not lost on this group how important this is, especially right now. So we really thank you guys all for joining. And as I said before, there might be some slight interruptions of folks in and out, but I'd like to welcome Dr. Rainey to the stage.
Thanks, Christian. And I want to give a huge thank you to you for putting this together. For those who don't know Christian and his work, he is absolutely one of the leaders in this field within emergency medicine and has been our Yale logo of bulldog, but he has been a bulldog about getting this together and getting us on the schedule. So it's really nice to see you all. I'm going to take us through objective number 1, which is a brief kind of overview of what we know and how emergency medicine has already contributed to creating solutions before I hand it off to my 2 colleagues. I'm going to try to keep it to about 10 minutes. We'll probably save Q&A for the end, yes, Christian, rather than after each of our segments. So I am both an emergency physician and a dean of a school of public health. And so my approach to firearm injury has always been from the public health perspective, right? When I started my training, when I started doing this work, inspired by Steve Hargarten 25 years ago, right? No one was talking about firearm injury as a health problem. It was purely a criminal justice or political problem. And the approach that Steve inspired me to take, and that I have then spent my career kind of recreating in the world, is the idea that we can take a public health approach to firearm injury the same way that we approach other epidemics. This chart shows along the x-axis are years in 5-year increments. The y-axis is rate of deaths per 100,000, so corrected for population size. And I'm showing 3 different epidemics: car crashes, firearms, and HIV. I put the 3 of them on the same graph because car crashes are one of our great injury prevention successes of the last 50 years. When I was born, car crash deaths were at an all-time high. We've since seen deaths decrease by about 70% by applying a public health approach, and I'll talk through kind of what that looks like. We've done that, very importantly, not by banning cars, but rather by making them safer, by educating, through enforcement and passage of laws, and through some really complex data collection that is still ongoing. Thanks to that public health approach, when we saw an uptick in car crash deaths around 2020, thanks to both the pandemic, quicker driving, more texting and driving, we very quickly responded by putting kind of a full suite of public health interventions in place to try to stabilize the rate of car crash deaths. HIV/AIDS, not an injury prevention story, but also a very classic public health story, right? In terms of how we've obviously saw a huge rise in deaths as it was first discovered, major decrease since, not by banning sex or by banning drugs, which we found didn't work, but rather through kind of a complex suite of public health approaches, ranging from antiretrovirals to syringe exchange programs to condom distribution to PrEP. And research and data helped guide us in how we got there. And now compare it to the red line of firearms, right? Where we saw a dip in deaths largely due to the decrease in homicides after the drug wars of the 90s. But then since about 2006, we've had this inexorable increase in the number of firearm deaths per year. I don't have injury data on this slide. For those of you in the room who are injury prevention folks, you know it's because our injury data is not great. But the difference in how we've approached firearm injury versus the other epidemics is that up until about 5, 7 years ago, we really didn't apply this public health approach. I will say we saw a 30% decrease in firearm homicides last year, and I can talk through why that is. I would posit that it's partly because we were applying this approach. But so this is death data, and this is like the highest level data on what the kind of patterns of firearm injury are. Again, seeing that increase in firearm deaths since about 2006 due to both firearm suicide and firearm homicide, with a lesser amount due to unintentional injury. When we think about the public health approach, and particularly from the emergency medicine perspective, right, we think not just in terms of overall numbers of deaths, but also trying to kind of go in and say, where are the deaths happening and to whom? This slide shows a paper done by one of our colleagues, Kit Delgado, who's emergency medicine at Penn. He worked with a team of folks to look at where there are hotspots versus cold spots of firearm deaths by county. Each of us practice in a different setting. We probably see somewhat different patterns of firearm deaths. And any of us who have been practicing more than a couple of years know that there are periods where we see deaths surge, and there are periods where we see deaths decrease. And what Kit tried to, and his team tried to do, was to look at where those deaths are more likely to happen and where they're less likely to happen, all other things being equal. Um, this is quite interesting as we think about kind of how to address firearm injury, because it starts to give us clues about what some risk factors and some protective factors might be. So if you can identify counties where firearm deaths are more likely to happen and counties where they're less likely to happen, accounting for the number of guns, accounting for the socioeconomic status, accounting for rurality, you can then start to examine what are the characteristics of those counties and design interventions accordingly. Not surprisingly, as I've already said, we find in those analyses that access to a firearm is, of course, one of the major drivers of firearm injury and death. Other emergency physicians, including one of my former mentees, have worked over time to look at patterns of gun ownership in the United States. Our gun ownership in the US is higher than any other developed country, and honestly, any other country in the world that collects data. We have about 120 guns per 100 civilians. So, yes, that's more than one gun per person. But the proportion of households that has guns has stayed very steady over time. About 40% of households have a gun. That has been true for as long as we've been doing surveys in the US. What has changed is a couple of things. We've seen increasing number of guns per household, and we've also seen changes in the reasons why people say that they're owning a gun. If you go back in survey data, going back in time, you find that most people say that they purchased a firearm for hunting, because it's a heritage, because they go shooting with their kids for shooting sports. Protection of kind of livestock was part of it. But now the vast majority, nearly 3/4 of firearm owners, say that they own a gun for personal protection. And we're finding that who is a first-time firearm owner has started to shift, with an increasing proportion of folks who are first-time firearm owners being female, Black, Hispanic, and then there's new data also showing LGBTQ plus individuals and folks who are religious minorities are increasingly likely to purchase a gun, again, with that reason of kind of a desire for personal protection. So this is kind of the basic epi of the problem, is that we're seeing this increase in deaths. We see it somewhat unevenly distributed with different counties with risk and protective factors. And we're seeing an increase in overall numbers of firearms and changes in the demography of who owns firearms, although the overall number of firearms or the number of households with firearms has stayed steady. So from that, we then move into kind of what can we do about it. So I started by saying we apply the public health approach. Many of you in this room are familiar with this. I know some of you have MPHs already. But the 4 basic steps that we come back to are that we gather data, we identify risk and protective factors, we then develop and evaluate interventions that either decrease risk or increase protection, and then only after we've done all that do we scale up. So I'm now in my last couple of minutes going to take you through some of the ways in which we've gotten the data, risk and protective factors, some of the interventions that emergency medicine has led in over the last 5 to 10 years since we restarted this approach of the public health kind of lens on firearm injury and death, and then I'll turn things to Christian. So within that four-step approach, we talk about there being interventions across multiple levels. We know this as emergency physicians, right? When we're treating a patient at the bedside, that's all about the individual level intervention. But we also have to think in the public health approach about how we deal with the family, how we deal with the community, or how we deal with a problem on a societal level, right? It's the difference between me taking care of a guy who's undomiciled and has cellulitis and just giving them antibiotics and maybe admitting them because they don't have anywhere to stay, versus working on kind of with their family to create a care plan, versus working to make sure that there are more shelters available, right? Versus thinking on a whole of society level about how we increase access to housing, taking that same approach to firearm injury. On the individual level, we talk a lot about risk factors. And I'm sure that many of you have heard about some of the interventions that we're doing to try to train healthcare providers, particularly emergency physicians, to recognize these risk factors and then take action on them. Four main risk factors for firearm injury acutely in the moment when we're taking care of them in the ED are, of course, a history of domestic violence. If you are a victim of domestic violence or a perpetrator and there's a gun in the household, it's about 5 times the likelihood of intimate partner homicide. So here, knowing about the risk factor, if you screen for gun access, it increases your concern about safety and that importance of that social worker handoff, calling the domestic violence hotline, et cetera. Depression, second huge risk factor, right? When I went to med school and did residency, we never got trained to ask about firearm access as part of our suicide screening. Hopefully all of you are doing it, but for those who have trainees, continuing to emphasize the importance of that question as part of the suicide screening is critically important. We don't often see those patients, the firearm suicides in the ED, but it is 2/3 of cases. Dementia is an increasing risk factor for firearm injury and death on the individual level, and a number of our fellow emergency physicians are working to think about how we can identify whether someone has an unsecured firearm in the home when we are taking care of folks with dementia who are there for a safety check because their family doesn't know how to take care of them, et cetera. And then, of course, prior fights, because one of the biggest predictors of future firearm homicide is having been in a fight or having been shot before. And I'll talk about the interventions for that. On an individual level, we're also working to think about how folks use social media. We know that kids are using social media to instigate fights. We know that it's a huge source of problems in terms of firearm injury, and so we're developing individual level interventions to address it. This is one example of an emergency department-based intervention that I've been lucky enough to lead, where we're actually using text message with teens who present to the ED for any reason and have been in a prior fight. We've shown that this intervention actually decreases future fights, thereby decreasing risk of gun violence. When we start moving out from that individual to the relationship level, I mentioned fights being a big risk factor. Here, I'm happy to talk in Q&A about the nonviolence programs that have been shown to be tremendously effective. There are hospital-based nonviolence programs. We have one at Yale. There are community nonviolence programs that kind of provide mentoring and kind of general interventions. And there are hotspot programs in the community that specifically target folks who are at that highest risk. All three types have been shown to be effective, and all three can be led by emergency physicians. At my last site at Brown, and Jeff knows this, we had a community nonviolence program that worked very closely with us. So for those kids with a history of fight, they could come in. At Yale, we've got one that's actually based in the hospital. In Chicago, most of the programs are hotspots. So depending on where you live, you may find different types of programs you can work with, but many of them are led by emergency physicians. We can provide both that hospital linkage and access to data that these programs often don't have. Finally, on the suite of interventions, as we go from individual to relationship to community out to society, I of course have to talk about laws. Here, emergency physicians have been amongst the absolute national leaders in terms of documenting the efficacy of policies on decreasing or increasing death. This plot comes from RAND. It shows the effect of different types of laws on the left on different types of injury or other firearm-related outcomes on the right. Blue means it decreases, orange means it increases. So for example, concealed carry laws and stand your ground laws increase violent crime. Child access prevention laws, also known as safe storage, decrease the risk of suicide and unintentional deaths. I'm happy to send you guys the reference. It is a terrific resource for those of us that are interested in policy work or advocacy. And I'm going to do one final shout out here to red flag laws. We have red flag laws in 22 states plus DC. Basically, those allow us or family members or police, depending on what state you're in, to get the equivalent of a domestic violence restraining order for someone who is particularly high risk for firearm injury or death. They're high risk of a mass shooting. We've probably all taken care of those patients in the ED. They're high risk of firearm suicide, but you can't quite get them committed. High risk of domestic violence, or potentially high risk of unintentional injury, although that would be a strange thing to use a red flag law for. I encourage you, if you are one of the blue states, to learn about your red flag law and to help educate your colleagues on the fact that it exists and how to use it. You will find that your hospital risk management very rarely knows about it. Your police force will very rarely know about it. In Connecticut, we were one of the first states to have a red flag law, and yet it's virtually never used by healthcare providers, although we're allowed to in Connecticut. So this is a huge area, again, where we are the ones who see these patients in crisis, and there have been studies showing that they do decrease suicide and have an effect on mass shootings. Lastly, I would be remiss to not talk about those bigger structural factors. Gina South at Penn has been a huge leader in terms of community improvement as a factor in reducing firearm injury, right? Of course, it's access to the gun, but it's also socioeconomic deprivation, structural racism, redlining, et cetera. And of course, also, we've been huge leaders in getting the funding that allows us to do this work so that I could present this talk in a way that I could not have done 10 years ago because we didn't have any of the data that I just talked about. So if you do nothing else from my part of the talk, it is to go out and advocate to make sure that we retain the money to CDC, NIH, and others that allows us to do this research, that allows us to then go and implement programs that work. With that, I'm going to turn things to Dr. Pulcini. Thank you.
And I'm going to fly right through this because we have a hard stop at 8:50 because Dr. Rainey is going to receive the Public Health Award from SAEM at the plenary session. So very well-deserved award. And I know Dr. Hargarden's got some really good stuff behind me. I am the early career person in the group, and I'm just making that notable for those early career folks out there that this is the power of just emailing people who are passionate about an issue, and then you get to do a didactic with them, and they answer you. So I would highly encourage you to get involved. And this is how I actually got involved in firearm injury research. Is I saw some clinical cases that were quite disturbing in children, and then it basically I couldn't. It's one of those things that keeps you up at night. Like my mentors would always say, do something about the things that keep you up at night. And this is certainly that issue. So I started studying that after seeing some clinical cases. I don't think it's lost on this group that firearm are a leading cause of injury and death among children and adolescents, and the leading cause of death among youth in general. And you see comparison to other countries, not only is it the guns, but the firearm mortality. Yes, that graph is small. I don't think it's not a hard guess who's on top of that by a long stride. So you don't even need to read it to actually comprehend what's going on there. There's very limited research on pediatric firearm injury, and this is taken from a paper that Dr. Rainey was actually involved with. A 30-fold increase in firearm injury research funding focused on this age group is needed for research funding to commiserate the mortality burden. So you can see maybe you can see because it's again small. So on the left-hand side is funding, or on the y-axis is funding, on the x-axis is mortality, and you see firearm injury is high on the x-axis, so it has high mortality but very little funding. You can see childhood cancer is very well funded, and deservedly so, of course. We're not saying that another disease or process should be less funded and we should trade off, but we're saying that it is not equal the mortality burden, and therefore we should be asking for funding, as Dr. Rainey just said. I was inspired by a clinical case. I'm not going to go into that entire story today to start this group. I was involved in the Children's Hospital Association, who has this research consortium and sort of process and already in place. And I approached the lead statistician, and this is again a good story for an early career person. And I said, we were at a party at a meeting like this. It was actually on the Pediatric Academic Society meeting, and I said, hey, firearms are a leading cause of injury and death in kids. Like, why don't you have a group that's dedicated to that? And he said, send me a proposal on Monday. And I'm like, oh, okay. And I was a fellow at the time. And I thought, wow, this could be really cool to get a bunch of good people together who are doing this work. No funding needed. The CHA just does it. And they provide a biostatistician as well as like a program manager that helps sort of mitigate these groups. So I thought, I guess I got to write some objectives and think about what to focus on. And so I started digging into the issue, and I saw for every one child who dies from an injury, the 4 more survive. And that was my experience in the emergency room when I was at the Children's Hospital of Philadelphia as a fellow, is that several would even be discharged from the emergency department. But there are a lot of firearm injuries that happen in kids. And I saw that in 2020, there's 11,258 non-fatal injuries among kids, and that very little research, like very little, if any, were focused on those that survive. And I always go into these projects thinking all are preventable. We should be preventing all of these injuries, or at least working towards that. So I talked about addressing these non-fatal firearm injuries as a first effort with this group, and I will just back up and say I use that as a platform to invite a whole bunch of senior investigators in the field of firearm injury that I've always wanted to work with, and it worked out really, really well. But we looked at health outcomes and healthcare expenditures for children pre and post injury. We were able to use the Medicaid market stand database to look before and after. And we wanted to compare the healthcare encounters for children 1 year before, and then we followed them for 1 year after their index firearm injury. And what we saw were significant increases in healthcare encounters, chronic disability, and expenditures. This is one of the graphs that we've taken from it, and this is expenditures. And you can see we looked at outpatient and inpatient as how we broke it up. And you can see the inpatient costs after the firearm injury skyrocketed, essentially. And these are for kids who survived the sort of index encounter. There's a lot more data in this. How we measure disability before and after, that's actually my primary area of research, is kids with medical complexities. So we have this proxy measure in there. And we're working on better characterizing the disability before and after as an important way to move this field forward. When we were doing this, we also noticed that mental health expenditures were really wacky amongst these kids. And so we didn't focus on that in the first paper. We said, let's put this aside so we can put some real focus on this. And so we looked at this gap of our knowledge of mental health service use after the firearm injury as well. And then we charged ahead. That's not really that funny of a joke because our group is called Charge, but I'm realizing that now as I'm standing up here. What we found for mental health was really interesting, that there's no change in overall utilization and a significant decrease in expenditures for mental health after the firearm injury. It made no sense. It's still a little bit puzzling, and we're still digging into the problem. I'll show you some of the following publications that we've had. But we looked at what's like considered a healthy population. So these are kids. 80% of kids in this country are pretty healthy. They don't really require any services beyond their primary care provider. I guess that's the easiest way to summarize that. We found their mental health expenditures, their utilization went up 131%, and their expenditures went up 229%. So this group of kids who had no mental health care services before had an increase after the firearm injury. So good thing, probably needed. We don't really know because this is like population health data. It's not individual level data. But those that had high prior mental health care utilization went down significantly, 44% utilization and 52% expenditures. We hypothesized that maybe the injury was severe enough with physical issues they had, but it doesn't really make much sense why kids who are getting mental health services, and this is like 50 visits in a year, so they're probably getting weekly therapy through this database we had, are not getting it after the firearm injury. We still don't know why. If we talk about a gap, this is certainly a gap that could be done on the local level. And I'm happy to give you gaps in firearm injuries in kids. I'll give them away at this point because there's so many of them to fill. We also found in another study that children who suffer from firearms have 50% greater odds of a new mental health diagnosis within a year of injury. This was sort of us digging into this issue using other databases and comparisons compared to children involved in motor vehicle crashes. And up to 2/3 of children do not access mental health services after a firearm injury. This was another paper that came out with this group. We also, it was actually Steven, I have to give him credit for this, talked about that maybe we need to start thinking about a holistic approach to firearm injuries, that it's not just the injury itself, that we need wraparound care for kids in every stage of when we're talking about injury prevention to after the injury. These are the studies that we've now published in this group over the last like 5 years. So it's been an extraordinarily productive group. And I will say, I don't know what it is about firearm research, and I don't know what it is about having it be unfunded, but I've never been in a more responsive and motivated group. I will tell you, you can email this group on Tuesday with an entire paper and say, we'd love to get this in 2 weeks. And every single person in this group will have answered by Friday. Half these people are like division chiefs and have operate like it is really an extraordinarily motivated and again unfunded group that is very passionate about this. So if you're passionate about this issue, I absolutely encourage you to reach out because people are very, very willing to work with you. And then a plug for translating research to advocacy. Every time I publish a firearm story, I contact our media relations and make sure that my colleagues are doing it at their institutions as well. And it's really, really important to get the word out. This is an article I wrote in the Vermont Digger. We can prevent firearm tragedies, a call to action. And by the way, I didn't even mention the little cartoons up at the top, if you noticed. Dr. Rainey had the Yale Bulldog. I have the wolf, so I know which slides are mine. I always find this fun. And the reason why I have the wolf is because I asked my 6-year-old daughter what I should be. And I don't know how to interpret the fact that she called me a wolf. With that, I'm going to pass it over to Dr. Hargarden. Who is the owl of the group?
I was going to say, we don't have a mascot for our medical college of Wisconsin, so I'm not sure what we're being called these days. But great. Thank you so much for being here. It's an honor to be with these two great panelists. And you've seen a great overview by Dr. Rennie. It's a notable issue that Megan Rainey leads a school of public health and now is in a position to influence public health more broadly than ever before from the bedside where she started. This is truly an accomplishment and a noteworthy recognition by SAEM moments from now. And it's a privilege to be working with Christian in the group that he describes. It's an honor for me to be in that group. It is an amazing group of people who are all collaborative, and CHA is an extraordinary resource for supporting this research, and it really has been great. I'm going to take you to a more basic science discussion about this problem and see how we can further understand it. I was hoping that Secretary Kennedy would join me in this conversation about the disease model, which has evolved, my understanding, since the 1800s, and that things like bad smells and miasma were kind of thought to be part of the disease process and has since been not necessarily associated with diseases. But maybe I can get to Senator Kennedy at another time. But I think the disease process is really what I'd like to focus on because it helps us strategize and build on that public health model that Dr. Rainey so eloquently described. You have a cause. Cholera is caused by a bacteria. The mechanism of development, the pathogenesis, we study that in medical school, nursing school, the structural alterations to cellular organs and to cells and organs, morphological changes. And then they present at the bedside in emergency departments around the country. That's the disease model. Applying that to firearm harm is helpful to understand, well, how can we do better in strategizing about ways in which we can prevent this? Because we have these causes and etiologies of cellular injury, and for injury prevention and control, it's physical agents. In this case, in bullets, it's kinetic energy. It's also from car crashes, falls. And you've got chemical radiation, thermal and electric energy. Those are those physical agents causing the injuries that we see in the emergency department. So really a good way to model our approach towards this. And we've learned from infectious diseases. This is a vector carrying a parasite. Malaria is Italian for bad air. Really? Malaria comes from bad air? No, it comes from a vector bringing that parasite to a human. So bringing that to firearm injury, we now have a microscope for our disease. We now can examine that pathogen in a way we've never been able to do before because we've got the video technology to do it. Just to give you a little fun history, if I can do this, I was afraid this might not work with this pointer. It could,
Hit that.
yeah.
Hit it.
The what?
Arrow options, maybe? No. Highlighter, maybe? No, it's not going to highlight it.
Oh, shoot, I gotta show this video. This is great. How do I do this? Erase all ink on the slide, eraser, laser pointer, pen.
Give it a try.
Now, this worked when I went
Yeah,
through the process.
Pointer. We messed it up when we did the laser pointer.
Yeah, I think that's it. Let me get this. Wait a minute. Yeah, you go. Good.
I've heard that you're a low-down Yankee liar.
The movie? Shane. Jack Palance, bad guy. Notice how he went across the room? I did it too quickly. Sorry. Sorry about that. Shoot. There it is. Okay. Sorry.
I've heard that you're a low-down Yankee liar. Prove it.
So that's physically impossible with Newton's laws. It just doesn't happen. That's the mythology of our understanding of bullets and what they do to people. And we need a better understanding of that. And we went to the crime lab in Milwaukee to start to study it. And this is the picture of the crime lab where we've got in the forefront is the crime lab technician who's all things firearms. And he has his lab to understand the forensics of a firearm injury. But we wanted to study the behavior of bullets. And distally, you can see in that picture is where the gelatin is, where we're studying the bullet's behavior as it goes through the gelatin with high-speed video camera. Let's see if this works. Right to left, bullet is going through the gelatin. It's a 25 caliber, low caliber. You see that little stretching that occurred? That's the temporary cavity. Then you're seeing right now the permanent cavity. That's directly in line with the bullet. That's the permanent cavity, crushing tissue along its way. The temporary cavity, though, stretches adjacent tissue. This is a 40 caliber. Notice where the temporary cavity gets formed. More proximal to the penetration. Look at the disruption now relative to that 25 caliber. The temporary cavity, larger, a lot of tissue disruption as seen in the gelatin, and the permanent cavity formation. Very different, predictably a different outcome for the patient. Now, this is a Thompson 45 Auto. Thompson machine gun, if you may recall, the machine gun that was used by gangsters and so forth in the 20s. It was regulated in 1934. It uses a 45 caliber bullet that's similar to a handgun. Look at the difference in terms of its destruction in the gelatin. A different mechanism, a different temporary cavity, different permanent cavity. Imagine again the outcomes for patients. Very different kinetic energy profile. This is a 5.56 NATO, which is used in rifles, AR-style 15 rifles. These are the common ones also used in mass shootings. We studied Sandy Hook, Uvalde, and Parkland, all with the same bullet, all with the same energy. Same gun, same bullet, same school setting. We had different outcomes of those patients. no child struck by this bullet at Sandy Hook survived. And you notice the tremendous destruction, not only of the permanent cavity, but the temporary cavity formation that results from this bullet entering into this gelatin and the disruption. The Uvalde perpetrator walked in and bought a Aristyle 15 rifle at 18 years of age. He bought 1,600 rounds of this ammunition. No questions asked, no taxation. So we wanted to also understand this temporary cavity in a way of distal tissue. What happens to bone if it's proximal to this bullet and its temporary cavity formation? And we fired the bullet 8 centimeters away from a porcine femur, which we embedded into the gelatin in the maximal portion of the temporary cavity, and we fractured the bone. So clinically, it's important for us to understand that proximity may imply a bone injury, a nerve stretching injury, perhaps other vascular injuries that we hadn't thought about because, well, it's a little bit away from vital structures. Well, we still have to think about it. And I think that's really an important clinical outcome that we're starting to understand based on caliber, but based on the kinetic energy that we are now quantifying in the gelatin. So this cliche that we've heard for decades, guns don't kill people, people kill people, I think needs to be modified, as Senator Moynihan said in the mid-1990s when we called attention to the black talon bullet, which is a hollow point bullet that was manufactured and disseminated in the civilian population. And change that. Guns don't kill people, bullets do. And we now can see them. We can understand their behavior. We can quantify the energy and classify those bullets in a way that is leading to an understanding of their wounding potential, their risk profile, their case fatality rate, if you will. We do that for bacteria. We need to do this for bullets and the guns that carry those bullets. Interesting study that I found in the social epidemiology text. The upper graph and the lower graphs are comparing Chicago homicides with Wales and England homicides by age. That's the horizontal axis. Look at the age distribution of homicides in both of those settings. They're identical. They virtually haven't changed in decades. But look at the vertical axis. Chicago death rate in homicides is 30 times greater. Why is that? Are Chicago 18-year-olds meaner or they somehow are more effective? No, it's bullets. They have access to firearms. And so the death rates are affected by that access to a product that carries a pathogen that has lethal consequences. So to finish up here so we can have time for questions back and forth, research questions to inform clinical care and policy discussions. Do adjacent nerves in the temporary cavity of a gunshot wound experience excessive damage, cellular disruption? We're now studying this. We're beginning a study with our colleagues in basic science. We want to do the same thing we did with the porcine femur. We're going to do this with nerve tissue, see if that stretching occurs proximal or adjacent to a gunshot wound. For long-term evaluation, we're seeing patients 2-3 months later complaining of pain, complaining of neuropraxias. We want to investigate that more thoroughly, investigate perhaps therapeutic interventions. How does caliber of bullets affect clinical outcome? We want to more actively link the non-fatal injuries of firearms with the caliber of the bullet. And we're undertaking that in Milwaukee and Indianapolis. We want to do this more with other studies that link the caliber with an outcome. We want to do that more, given that there was a great study done with Boston data by Anthony Braga showing that caliber matters. And by adjusting rates of what calibers were used in homicides, if they all used a lower caliber, the homicide rate would be decreased by 40%. Instrumentality matters. If you grab a gun or you grab a knife. I keep hitting this thing, damn it, Jesus. And on what data is needed to develop a civilian lethality index for bullets and firearms. That's where we want to go with this study. We're going to England later on in June to continue these studies in ballistics, and we want to do a spectrum of firearms to understand not only the scope and nature of the current firearms that we have available to people, but also historical firearms, including a musket rifle. and demonstrating what does a musket ball do in gelatin compared to an AR style 15 rifle bullet 5.56. Compare and contrast, I think will be implying some perhaps a different policy discussion. And I think that's where we're really headed towards that being the discussion and it's being science driven. So with that, I will stop and really we're looking forward to a robust question and answer period. So thank you very much.
All right, we have a microphone. Not really sure that it's needed in this room, and I hope you all certainly learned something through all three of these presentations. I learned that Dr. Hargarden uses his hands to talk more than my Italian family. So, but if anybody has any questions or anything, I mean, you're free. I think we're free to have a discussion for at least the next 8 minutes.
About the decrease in mental health services. What was the period of time in the window after the event?
1 year.
So were these kids, I was thinking, were they hospitalized? Like, were they so severely injured that they were actually inpatient?
It follows pretty clearly epidemiologically when we look at it. About 50% are discharged from the ED and 50% are admitted.
And the decrease in services was equivalent for discharge versus?
Yes. It doesn't make much sense.
Yeah, I'm just imagining, like, if you are
Severity higher?
well, no, not severity higher, but if you are just constantly engaged in medical care, that maybe you don't have time to, like,
Yes.
you're going to physical therapy several times a week, and you're going to
Yeah.
the pediatrician and follow up with the trauma surgeon, and maybe you don't get to, the therapist, but.
That's what we thought as well. It doesn't seem to pan out yet, but we also need more granularity in the data to be able to figure it out.
Sorry, it's a two-part question.
And you might introduce yourself,
Yes,
please.
my name is Ronnie Otero from Medical College of Wisconsin. So the first question is actually for you. So you mentioned in some of that data that the first-time purchases, 72% is for personal protection, but you also mentioned that the number of handguns or the number of guns purchased is more than one per household. So my thought is, when you have more than one gun, chances are you're not like shooting two at the same time. So does the motivation for purchasing more guns tend to be less for personal protection, more like for recreation or other reasons and more the higher risk factor?
It's a great question. So we actually find that people that purchase for personal protection are more likely to own more guns, and there's a couple of things. One is that we find that there is a kind of another talk where I talk about kind of the issue culture around firearm ownership, and we find that folks that are kind of very into the idea of firearms as being a source of personal protection want to stage firearms
Yeah, the only data that I've seen that has sort of characterized anything about the parents or family came out of NGH or Missouri. Yeah, that we put in. So we actually have a review of utilization coming out in the journal Pediatric soon. It's like a state-of-the-art review. So luckily I can answer this question. But they looked at the family's mental health services. They didn't look at specifically the family's involvement, but the family's mental health services. And unsurprisingly, that after their child was shot, their mental health services increased as well as their like overall health utilization. So I forgot what I think they did use some sort of Medicaid database that they could link it to the families. And when they link it to the families, they're finding similar findings about the parents as the kids. That's the only thing I'm aware of that has looked at the parents specifically with kids after they're injured. But I mean, that is a fantastic question. And then even how much it affects communities when because we hear quite a bit when I was in West Philadelphia specifically. It's like kids, like we had a kid shot in the neck, and fortunately survived. And I remember another family coming in and knew that family, brought it up, and it was like, now we don't let our kids outside.
So related to that, there's actually been studies, Gina's house, again, here in Philly, did a study looking at after there's a shooting in a neighborhood, you see an increased number of pediatric mental health visits to the emergency department amongst kids that live within a quarter mile of that shooting in the 2 weeks after the shooting. You don't interestingly see an increase in mental health visits or in acute kind of stress-related complaints in adults. And the theory is because, at least in Philly, is because of by the time it gets to be an adult, it gets to that point you've had such chronic exposure to trauma in the areas where shootings frequently happen that you don't see a bump in those acute mental health visits. There have also been community-level studies looking at school test scores after a shooting in the neighborhood. Again, you don't know, like, don't necessarily know this person, but after there's a shooting in a neighborhood, you see a decrease in school test scores in a couple of weeks afterwards, which is really important as you think about that ripple effect, right? Like part of, as we're thinking about, like there's the clinical care aspect of what we do, right? We want people to take the best care of the patient, but to your point, Betsy, it's also about how do we think about creating change on but it is more, I mean, particularly like I said, but like, or if you're gonna